My presentation is divided into 6 sessions: epidemiology, pathogenesis, and genetic, clinical feature, workup, treatment, and conclusion. I will focus on the treatment. First of all, I would like to mention about epidemiology of essential tremor. An essential tremor is the most common cause of action tremor, with an estimated worldwide prevalence of 0.9% and about 5% in people over 60 years. And the incidence increase with age, and the prevalence of essential tremor is similar in male and female. Essential tremor may present a syndrome of related disorder rather than a single disease. Wide range of clinical features and genetic findings can be reviewed in patients with essential tremor. A family history of tremor is present in 30 to 70%, suggesting a very strong genetic component. The proportion is 80% if onset before age 40. First-degree relative essential patients had an increased risk of developing the disorder. Lack of 100 concordance among identical twins suggests other factors may play a role. Some specific high risks have been identified. Neuropathology of essential tremor remains poorly understood and controversial, but cerebellum and brainstem have been most commonly implicated. Most studies have identified structural abnormality in various parts of cerebellum. Essential tremor is an action tremor, and it affects hand and forearm. It can also affect the head, right face, and leg, commonly strong and legs. The tremor frequency is considerable variability from 4 to 12 Hz. The tremor may vary from low amplitude high frequency postural tremor of hand to a much larger amplitude tremor. Essential tremor is typically bilateral and is often slightly asymmetric. Tremor can be made by stress, anxiety, excitement, high adrenaline, stage, chocolate, pain, and lack of sleep. And essential tremor is improved by small amount of alcohol or avoidance of sugar. Essential tremor tend to worsen gradually over time. Many patients have symptoms for years before they seek medical attention, and spread to previously uninformed reasons may also occur. Disability of tremor can be significant when it affects writing, holding brain, eating utensil, or signing the document. So there are many studies have been shown that essential tremor can have a significant negative impact on quality of life. In terms of workup, essential tremor is a clinical diagnosis. So the goal of the evaluation is to identify characteristic features of essential tremor and to recognize any typical feature that may suggest an alternative cause of tremor. Routine blood tests should be performed to exclude comprehensible cause of enhanced physiologic tremor, including electrolyte thyroid function test. Wilson disease should be excluded in anyone under age 40. Neurophysiological analysis can confirm central neurologic oscillation of ET and contract to medical reflex in enhanced physiologic tremor. Structural brain imaging is not required in patients with typical clinical features of essential tremor. The International Parkinson and Movement Disorder Society defines essential tremor by following features: isolated tremor syndrome, a bilateral uplift action tremor, at least 3 year duration, with or without tremor in other locations, and absence of other neurological signs such as dystonia, ataxia, and Parkinsonism. The International Parkinson and Movement Disorder Society consensus statement also define diagnostic criteria of essential tremor plus. Tremor with the characteristic of ET and additional neurological signs of uncertain significance such as impedance, tendencies, questionable dystonic posturing, memory impairment, and other minor neurologic signs. ET with tremor at rest should be classified. Diagnostic criteria exclusion criteria for ET and ET plus include isolated focal tremor, orthostatic tremor with a frequency more than 10 Hz, part and position specific tremor, and sudden onset and stepwise deterioration. Let's move on to treatment. Treatment of essential tremor is symptomatic. No disease-modifying therapy are available. The degree of tremor control vary among patients and often depend on the dose of the agent used, tremor severity, and the patient's individual response to the chosen agent. And the goal of the therapy is to reduce tremor severity enough to prevent disability while minimizing medication side effects. For patients with essential tremor, we have to answer the question, is there a need of medication? Firstly, medication or other substances that could be exacerbating tremor should be discontinued. Drug treatment should be offered to patients who had intermittent or persistent disability caused by tremor. For most patients with mild ET and little or no tremor-related disability usually do not require treatment. Some patients are bothered by the cosmetic effect of even the smallest amount of shaking. Some patients may develop exacerbation of tremor by stressful social occasion or public performance. Intermittent drug treatment can be useful in such cases. For patients with mild ET, low-dose propranolol can be used as needed. Propranolol may be also effective when used intermittently, but its slow onset of action limits its utility. Alternative options include a use of a low-dose short-acting benzodiazepine. In social settings, many patients found that a small amount of alcohol lessens tremor can to acceptable level. Patients with persistent functional or psychological disability include impairment or anxiety require daily medication. Propranolol and primidone are considered first-line therapy. They have equivalent efficacy based on small comparative trials and the choice based on side effect profile, concomitant medication, and comorbidity. This table provides evidence-based recommendations for treatment of essential tremor. Propranolol and primidone were classified at level A in treating limb tremor. Alprazolam, atenolol, gabapentin, sotalol, and topiramate were classified at level B. Propranolol were classified at level B in treating head tremor. Clonazepam, clozapine, nadolol, and nifedipine were classified at level C. Botulinum A in limb, head, and point tremor were classified at level C. Propranolol is a beta blocker medication. Propranolol with dose 60 to 320 mg per day is effective in treating limb tremor, and tremor magnitude can be reduced by about 50%. Responder rates range from 50 to 70%, and a lower rate of responder for functional improvement and for certain effect. Propranolol rapidly reduces head tremor, but data are more limited. Side effects of propranolol including bradycardia, bronchospasm, lightheaded, fatigue, and impotence. Relatively contraindications include asthma, heart block, unstable heart failure, and type 1 diabetes mellitus. The discontinuation rate due to side effects is less than 10%. Propranolol has also a long-acting formulation. In a double-blind comparative study with 50 patients, a long-acting formulation of propranolol taken once daily was shown to be as effective as conventional propranolol in reducing the amplitude of essential tremor. Let's talk about primidone. Primidone is an anticonvulsant medication. Primidone with dose from 150 to 750 mg per day is effective in treating limb tremor, and tremor magnitude can be reduced by up to 50%. Many studies have shown that an improvement in clinical rating for tremor severity such performance and measure of activity daily living. And there are some data to suggest that primidone may be effective in vocal tremor. Side effect of primidone is usually more severe in treatment initiation and may include sedation, daytime sleepiness, fatigue, nausea, depression, and ataxia. Acute toxic reaction occur at frequency as high as 22.7%, and the continuous rate from 7.5 to 42%. There is no evidence on the best titration regimen to reduce the frequency of the initial side effect, and primidone cannot be given along with anticoagulant. In a head-to-head comparison of propranolol and primidone, Patient preference were greater for primidone, but primidone got more bothersome side effects. How about long-term effect of propranolol and primidone? Based on studies, after 1 year of treatment, initial benefits were shown in 70% with propranolol and 68% with primidone. Acute adverse reaction occurred in 8% with propranolol and 32% with primidone. And chronic side effects occur in 17% with propranolol and 0% with primidone. Tolerance to the drug effect occur about in 30% in both groups. Primidone combined propranolol is considered as second-line therapy in patients with adequate benefits of first-line therapy. In one study, the combined use of primidone and propranolol associated with a greater benefits than either drug alone. Several other beta blockers also have anti-tremor effect. Nadolol is likely peripheral acting beta blocker, may avoid adverse central effect induced by propranolol such as depression. Atenolol is probably the best alternative to propranolol for patients with a relative contraindication to a non-selective beta blocker, and metoprolol had uncertain benefits for essential tremor. Topiramate is an anticonvulsant medication. Many studies show an improvement on both tremor amplitude and activity daily living measure. Side effects of topiramate include paresthesia, appetite suppression, weight loss, nausea, concentration, or attention difficulty. Adverse events were treatment limiting in 31.9% of the case. Discontinuation rate due to adverse events is quite high, from 30% to 54.2%. For upper limb tremor, topiramate was considered efficacious for daily dose higher than 200 mg with an acceptable risk without specialized monitoring. Positive efficacy results were documented for daily dose higher than 200 mg and not in a study assessed a 50 to 100 mg dose rate. Alprazolam were considered possibly useful for clinical practice, and side effects include somnolence and rate of dependence. Gabapentin is an anticonvulsant medication. Gabapentin as monotherapy had anti-tremor effects in some patients with ET, but on very limited data. Gabapentin as a therapy has shown conflict results, and side effects include sleepiness, weight gain, dizziness, and gait unsteadiness. About other medications, there are some data to suggest that clonazepam is possibly useful in treating limb tremor associated with essential tremor. In retrospective studies in the US, 64% of patients received one pharmacology treatment, and to their medication discontinuation were 40%. And propranolol was the most used, followed by primidone. In another retrospective analysis, we can see 27.1 patients didn't receive any treatment, and 46.5% received monotherapy. 18% of patients received two medications, and 6.1% of patients received three medications. And primidone was the most used, followed by propranolol, topiramate, gabapentin, and benzodiazepine. Patients with essential tremor refractory to oral drug chemically with botulinum toxin. Many studies saw an improvement in clinical rating of upper limb tremor, but no functional improvement. Therapeutic effects were maintained for 16 weeks, and dose-dependent hand weakness are the most adverse reactions. For head tremor, a double-blind placebo-controlled study was conducted to evaluate the efficacy of botulinum toxin in 10 patients with essential head tremor. Botulinum toxin is injected into sphenochleidomatoid and splenic capital muscle. There was moderate to marked improvement in clinical rating in 5 subjects after botulinum toxin injection and in 1 subject after placebo, but the difference is not statistically significant, and side effects were mild and transient, including neck weakness and post-injection pain. How about botulinum toxin injection for essential void tremor? In one study, 15 patients with essential void tremor were treated with botulinum toxin injection to the thyroid muscle and some case into circothyroid and thyroid hyoid muscle. And subjective evaluation indicated that the treatment had a beneficial effect in 67% of the patients. This slide shows current evidence-based strategy for medical treatment. For tremor, propranolol and primidone were considered clinically useful. So propranolol and primidone are first-line therapy. Treatment selection and dosing are based on individual patient characteristics, safety and tolerability, and additional therapeutic benefit. Topiramate were considered clinically useful with daily dose more than 200 mg per day. Amitriptyline and botulinum toxin A were considered possibly useful. There is insufficient evidence for void and head tremor. I would like to mention about a recent research. In a double-blind placebo-controlled randomized crossover trial, better panel was treated in 26 patients at monotherapy or as the anti-tremor medication, and better panel was superior to placebo on the primary endpoint, activity of daily living, and subject global impression of change, but not quality of life. Adverse events more common with parapanel include imbalance, bone dizziness, and irritability. An open-label phase 2 study was conducted to examine the efficacy and central effect of sodium oxybate in patients with alcohol response essential tremor of void. And sodium oxybate reduced essential tremor of void symptoms on average by 40.8% in 92.9% of patients. The central effect of sodium oxybate was associated with the normalized activity in the cerebellum, parietal lobe, inferior frontal cortex, and insula. This is a therapeutic algorithm for essential tremor. Firstly, we have to establish the origin of essential tremor. And then it is important in controlling essential tremor patients in education and support. Then we have to assess is there a need for medication. If then we have to like additive therapy or continuous therapy. For additive therapy, we can choose propranolol or use ethanol before anticipated event. For continuous therapy, we can choose primidone or propranolol. If tremor is not controlled, administer combination therapy, primidone and propranolol. And if therapy is not successful, we can add horsewhip to benzodiazepine, gabapentin, topiramate. And if therapy is not successful, patient can be treated with botulinum toxin injection or patient can be performed DBS. So in conclusion, essential tremor is the most common movement disorder, and some medication exist to have tremor, and propranolol and primidone are first-line therapy for upper limb tremor. But benefit of the treatment is usually incomplete, and number of patients refractory to bad pharmacological treatment is quite high. Thank you for your attention.